This is a very educational video, step by step, how to master the technique of intrauterine surgery and to perform safe and complete hysteroscopic myoma resection. As you will see in every second in the video, there is a message. Like in this clip, rotating around the myoma, circling around the myoma for assessment of the size, contour, and the attached base. This is nearly type 1, type 0 to type 1. There is a small intramural part. So I repeat again, when you watch any video, not only mine, when you watch any video, try to focus in the movement of the instrument, and also try to think with the mind of the surgeon. Surgery is a strategy. Where to start to cut, when to stop, when to change the direction of the electrode to move from one area to other. So learning surgical skills is not only learning the hand movement, not only the ergonomics, but also the strategy and the mind and the thinking. So another hint I tell you about, you can obviously see that in some areas the electrode does not move smoothly. That's because of calcification in some areas of the myoma. So what to do? If you keep cutting in the same area, the electrode will break and you will not be able to remove the tissues or to cut the tissues. So in that case, you change the area. Go a little bit up, a little bit down, or a little bit deeper to push the electrode into the flesh of the myoma and the softer flesh and avoid the calcified. As I tell you, there is a secret in every step. So I do my best while you're watching the video to draw your attention to the points which help you to master the technique. And another point to draw your attention that in this video, it is almost 8 minutes, and this myoma is about 5 centimeters. It is non-stop, non-edited. So you will see the challenges and the maneuvers. Here I'm cutting on the inferior part of the myoma, trying to identify the myometrium, but it was a little bit deep, so I moved more up. So starting on the most inferior part and then move, this is the most inferior part of the myoma, trying to reach the myometrium to identify the cut-off limit. When you see these bleeding points, you should realize that you're very close now to the capsule. So here we're near the capsule of the myoma. So I will leave you to enjoy, but I first draw your attention how to benefit from watching surgical videos. In few seconds, you will see the myometrium, and then you identify this is the lowermost part or the most deep part of the myoma. So let's continue more and more tips and tricks. As you can see that the chips of the myoma tissues are pushed to one side in the upper part of the uterus, and to avoid keep going in and out to clean, because if you go out to clean this debris, the cavity will collapse, some bleeding will happen. So when you go in again, everything will look red, clotted blood inside. And believe me, it is not like laparoscopy. In laparoscopy, you can have jet wash, suction. But in hysteroscopy, I don't believe any value of suction. The suction will add more confusion, because when you apply suction into the cavity, the uterine walls will collapse and you will not see anything. Here I'm trying to do backhand movement, but I realize I share with you every frustration. I realize that still the base is wide. To do a backhand movement for purpose of detaching the myoma from its base should be applied when the pedicle or the base is thin, is not very broad. But here, when I realized that the base of the myoma is still broad, I decided to change the strategy again and again. I share with you how I think. Again, I repeat that surgery is skills of the mind, not in the hand. Your mind gives the signal and the impulse to your hand to move. So changing the strategy, instead of backhand movement, I decided to keep on cutting into the substance of the myoma until I reach the base. At that moment, I think the pedicle will be thin. You can do the backhand movement and detach, like I'm doing now, and detach the myoma. Another common question comes from colleague Osama, what kind of electrosurgery you are using? Definitely bipolar is safer, but here I'm using monopolar electrocautery. This is monopolar resection. The difference that in monopolar you are obliged to use electrolyte-free solution. And here I repeat, the only permissible solution is glycine. Avoid distal water. Distal water is very dangerous. And fluid overload for a fluid without electrolytes is quite risky. Pulmonary edema, brain edema. But if you finish quickly, there is no big risk. Again, second question, what is the fluid pressure used? I repeat again, different than laparoscopy. In laparoscopy, you can set fixed number like 14 and 15 and keep operating for a long time. Here we're approaching now the myometer, and you can see the myometer. But in hysteroscopy, there is a leakage from the cervix, there's leakage from the fallopian tube, the size of the cavities are variable, so there is no number to tell. You adjust the pressure to the level which sustain adequate panoramic view and to maintain tamponade compression on the vessels. If your intrauterine pressure is less than the arterial blood pressure, so any cut in the tissues will lead to bleeding, trickling of blood into the cavity, which will mix with the fluid. Then you are operating within red wine or strawberry juice. You're not able to see. Now we can see the basal myometrium, so almost mission accomplished. The main myoma is removed, and then there's some little tissues, some little part of the capsule. So for perfection, you do like potato chip slices, and be careful because here if you cut deeper, you cut into the myometrium. I can confidently say that there is about 10 to 15% of myoma tissues deep intramural. So in a sense, it looked like a type 0 myoma, but actually it is type 1 because there is some intramural part. So my dear friends, keep watching, observe the maneuvers. I want each and everyone watching the video to move your hand and your fingers. Imagine that you are the surgeon. Try to replicate and repeat the movement. Imagine how I push the debris to one side and enjoy a nice panoramic view. Now we come to the end of the procedure. Myoma resection is completed safely in proper time. I do all my best to spread every skills, every knowledge I have, and to share it with colleagues from all over the world in my operating theater and bring skills to the hands of everybody. This is Osama Shawki from Cairo, Egypt. Thank you very much.